Good afternoon, everybody. Thank you all for coming. My name is Colin McKenzie, and I am the president of BRI here at the University of Louisville. Today we're going to have a healthcare town hall, try to keep a discussion on healthcare throughout this thing. First, Dr. Josh Umbehr of AtlasMD is going to come up here to talk. Following his discussion, Matt Bevin will come and speak to you all on the topic of healthcare. Once Bevin finishes his discussion, we will then have a Q&A portion where the audience is invited to come to the microphones. We have positioned halfway up the aisles and ask our panel composed of Dr. Josh, Matt Bevin, and Akash Chougule, any question that you might have regarding the topic of healthcare. So without further ado, I'm going to hand it over to Dr. Josh here, and he's going to tell you a little bit about his practice, AtlasMD.
Thank you all for having me. I think it's a great topic for med students to be aware of and be involved in. I try to keep these talks very informal, so please feel free if you do have a question, stop, interrupt me, raise your hand, and point me in another direction. I'll tell you a little bit about what I do and then the overall model of direct primary care. So I started my practice, AtlasMD, an insurance-free practice right out of residency. So I graduated July of 2010, opened the practice September 2nd, 2010, so we just passed our 5-year mark. We started off with one doc, no patients, and a dream to not go bankrupt. So far, so good. We now have 5 physicians and hopefully adding on our 6th in January. But the direct care movement overall has grown substantially in the last 5 years. So it originally was concierge medicine, this idea that if you were insurance free, the only way you could do it was to be high-end, expensive, unaffordable. I think the only difference between the term concierge and direct care is branding. Both models share a lot of similarities. But in general, it's an insurance-free model, not because insurance is bad, but because we're using it as a tool incorrectly. You don't have car insurance, home insurance, life insurance structured like healthcare. And if you would, it would be broken too. So insurance is for the expensive stuff, cash is for everything else. And that's how we structured our family practice. And all through residency, I saw too often that patients would pay their last $20 for the copay to figure out what medicine they needed, but not be able to afford it, quite literally selling your car for gas money. We knew there had to be a better way. I love working hard. I moonlighted a lot in residency, more than my attendings were aware of. But I hate doing paperwork. So I wanted a model that would allow me to work hard, take care of patients, but not just do the things that don't matter. And paperwork a lot of the times just doesn't matter. Insurance billing for medications that are affordable. So we said, if we're going to do this, how are we going to build a model that will work both for patients and doctors? And we went through a lot of different sample plans and ultimately came down to a membership. It is $10 for kids, $50 for most adults for unlimited home visits, work visits, office visits, technology visits like phone calls, text message, email, Twitter, Facebook, Skype. I don't have anyone Snapchatting me yet, but in theory it's possible. But because we don't take insurance, we're a lot more flexible to meet our patients, our customers, at the level that works best for them. Then we don't have any copays for anything in the office. Any procedure we can do is included as part of your membership. So EKGs, stitches, biopsies, joint injections, ultrasounds, DEXA, spirometry, Holter, cryotherapy, lesion removal, minor surgical procedures like toenail removal, all included for free. So how much does an EKG cost? And this is only fun if you guess high. $10,000, that's fantastic. You win the award for the highest price, yes. That's the most fun. 36 cents. Each sticky pad's 3.5 cents. So it's very affordable to do these things. And so we wanted to bring that much value to our patients that they can say, well, I'm paying for this membership, but look at all the things I have access to for cheap. So then to continue to add value to the model, we did something that's unique to 44 states, which allow physicians to dispense medications out of their office, but we do wholesale medicines, wholesale labs, imaging, and pathology. So I can get 1,000 Lasix for $8.33. It's under a penny a pill, even after my 10% markup. And we're very transparent about that. We mark everything up, cost plus 10%. Healthcare is a low-trust industry, and we want our patients to have high trust that they know exactly what our business model and pricing is. But even after my 10% profit, it's still under a penny a pill. That beats out Amazon, Walmart, Target, CVS. These billion-dollar companies, and one doctor with very few patients at the time can outcompete that. And so it's a very powerful business model and brings a lot of value to our patients. Other things like Imitrex, which, depending on where you're at, you can use goodrx.com to check out the cash prices. Local, I know it's between $88 and $256 cash price for medicine that I get for $6 wholesale. So now my membership is $50, but the medicine is $6. You have unlimited visits to your doctor, no copays, free procedures, and you're saving maybe $100 a month on your medicine. That's life-changing for a lot of our poor patients. But then even things like blood work. A CBC costs me $1.65, and again, that includes my 10% profit. So you can make healthcare incredibly affordable if you cut out all the middlemen. There's a phrase in business, turn waste into margin. Well, few industries have as much waste as healthcare. So we can do a whole lot of good if we remove a whole lot of waste. And I think it behooves the physician to look at business models to see how can we help our patients? How can we get them a better product every year? I mean, we're walking around with supercomputers in our pockets. And if my supercomputer breaks, I can go to the supercomputer store and I get to pick one that's the newest edition and in the color I want. All because of good business. And if I think often are taught that medicine and business can't coexist. You can't be a caring clinician and a really good business person. That somehow those two things are contradictory. What I would say is that if we take our O seriously of do no harm, it has to include do no financial harm. It has to say, how do I push down barriers and tilt into windmills to say, how do I get a medication for my patients cheaper? So I can take a low SES mom working at a call center who goes to the ER for migraine treatment because she can't get her Imitrex because it's $256 that I can get for $6. Or I save her the ER visit because the Toradol is $1 a shot for me, and I'll do it for free, even on the weekends or after hours. So it's a powerful new business model that gives us, the physicians, a lot of opportunity and puts us in the driving position to care for our patients better, bring them more value, more care, more opportunities for health, all without involving insurance. Now, insurance has its place. Car wrecks, cancers, heart attacks, these things do happen. My first daughter, when I was a third-year medical student, was born with Down syndrome unexpectedly. We spent 6 weeks in the ICU and spent $160,000. Very happy we had insurance and not crappy med student insurance. My wife worked and we had good insurance. That's what it's for. I have life insurance, but I never want to use it, right? I mean, the only person who gets value out of my life insurance is my wife and probably a cabana boy. Get it? Okay. Yep. All right. Wake up now. And so I don't want to use my insurance in that scenario. So it's easy paperwork. There's no abuse, etc. It's for something rare that probably won't happen, but it's affordable. So if we could make health insurance mirror that model, like car insurance, I'll pay for my own gasoline, tires, oil changes, but be there to protect me if something major happens. So now we can take all the value of unlimited visits, no copays, free procedures, wholesale meds, labs, imaging, pathology, both of which are 90% cheaper, and remove that from your insurance policy. Now we can go to an employer and decrease their premiums by 30 to 60% year one. And those are years where they're expecting a 20 or 30% increase. So we've had employers who've been with our group for the last 5 years actually pay less in health insurance premiums every year because of intelligently combining their insurance with the direct care model. And not because they never got sick. Things happen. They're going to happen. Someone is going to need more care, babies to be born, cancers to be diagnosed. But you blunt so much of that cost exposure that now things become very affordable. And that's what we're doing. We've seen a lot of success. And when we started our model, there was a poll that said 1% of physicians would be interested in an insurance-free model. Now the American Academy of Family Physicians, their latest poll showed 28% of doctors would consider an insurance-free direct care model. So we've gone from 1 to 28 in just 5 years. Not because we're so great, but because I think the model is so powerful. And as the current system continues to break, doctors, patients, employers, even insurance companies are saying, all right, We got to find a better way. This isn't working real well for anybody. Even the insurance companies aren't making a ton of profit off this. In fact, the ACA has something called the corridor rule, that if you make too much profit and another insurance company loses money, they have to give the profit from one insurance company over to the poor performing insurance company. So it's a cluster. But if we can go in and say that we can do this better, then we're helping our patients, we're helping their employers, we're ultimately helping their insurance, and we're helping ourselves. So in this model, a doctor sees 600 patients, typically, maybe 600 to 800, instead of 3,000. But we see them really well, really efficiently. And again, at those prices, this is affordable for a wide range of patients, not to mention just on the base price, but on the money saved. We've had patients who come from our community-sponsored free clinics, but they have a sliding scale. And so they'll pay $45 for a visit and $100 for a trigger point injection. Well, trigger point injection is 30 cents a lidocaine. We'll do that for free. I'm not a big trigger point guy, I'm not a big fibro guy, but if that's what my patient needs, it's a free service that she gets through us, and there's no copay. So this is a poor, otherwise low SES patient going to normally a free clinic who is benefiting from a direct care model like ours. And then that, of course, on up the chain, it values other people. So a lot of things we do is talk nationally about this model. We've helped over 100 doctors in about the last 18 months convert to practices like this. As ICD-10 kicks in officially October 1st, we've made October 1st a direct care holiday to steal back some of that attention and power, because doctors are seeing that now with less paperwork, they can provide better care for their patients. It's an exciting new model. Other fascinating examples of the money we can save a patient, even on expensive things like breast cancer treatments. We had a patient who had insurance, but her copay for her breast cancer medication was going to be over $600 for every 2 weeks at the pharmacy. That our wholesale price was just over $6. In fact, we were shocked too. I'm not familiar with the price of breast cancer therapy normally, but we gave it to her for free just so we could say AtlasMD, now providing chemotherapy. So we could do whatever we want in that model, and that's the fun part. I'll take this time to introduce our next speaker, and then we can do some Q&A after that, but I hope you found that much interesting. Mr. Matt Bevin is a Republican nominee for governor. He is husband and father of 9 children. Fantastic. I have 3 and I can't keep track of them. He is a veteran and a small business owner. Matt grew up in an old farmhouse where his family raised both crops and animals. His family of 8 shared 3 bedrooms and 1 bathroom. It was a financially humble home, but he was raised with a strong work ethic and solid Christian values. He attended Washington and Lee University in Virginia on an ROTC scholarship and then served as active duty as a U.S. Army officer. After his military service, Matt worked for many years in the financial industry. 17 years ago, a job opportunity brought Matt and his wife, Glenna, a registered nurse, to Kentucky, where they decided to put down roots and raise their family. Matt has founded several companies in Kentucky and invested in a number of others in the Commonwealth and around the U.S. He has managed and expanded multiple businesses, creating many good-paying jobs for hardworking Americans. These companies range from manufacturing to investment management to medical devices. In 2001, Matt also became the 6th-generation president of Bevin Bros, a small bell manufacturing company that began in 1832. He makes all the bells used by the Salvation Army volunteers each year. The company was bankrupt when Matt took it over and saved more than 25 jobs. Matt has served on many nonprofit boards, including as chairman of the board of the American Red Cross Louisville area chapter. He has permanently endowed several scholarship funds, grants, and centers that provide educational opportunities for young people with limited financial resources. Welcome to the stage, Mr. Bevin.
Appreciate that.
Absolutely.
Gave me time to get my shoes tied there before I came up here. Thank you all for being in here. I mean, a day like today, there's any number of other more tempting places to be spending your time, as many of your colleagues are doing out in the Quad area. So thank you for being in here. This is certainly a topical discussion. I think as much as anything, what I'd love to do is leave most of this time open to questions and answers, which we'll be doing here in short measure. I will just tell you very briefly about my background and why I'm in this race. I'm in this race, frankly, because we need people who are not professional politicians to put themselves forward. This nation was founded by people, Benjamin Rush among others, who came from the private sector, who were people who had livelihoods, who had avocations that were not professional politicians. They didn't come from a House of Lords. They intentionally rejected that as an approach to government. They didn't think that it was an entitlement. They believed that it was something where somebody who was to serve the public was to do exactly that, to be a public servant. Somebody who would do something at a cost to themselves, but for the betterment of their fellow man. That's the whole point of it. We've become, sadly, in both parties, largely removed from that. And politics has become a career path for people. I think that's a mistake. As was noted, I grew up in a fairly financially humble home, and frankly, so did, I'm sure, some of you in this room. So did a whole lot of people that you go to school with. So do a whole lot of those that you're going to be out there serving in these communities in the years to come. It doesn't make me unique, but it does give me a perspective. It does give me a perspective specific to even some of the things that we'll be talking about here, as it relates to some of these programs that are affecting. We'll let community, the questions from you all, drive this. But the ways in which we service those in our community, those who are on Medicaid, those who have true need, those with various impairments, physical, mental, etc., those folks who have need from society. That is something that each of you are going to wrestle with more than your average citizen will. And the decisions that are made by people who run for office are going to affect the decisions that you all are even able to make. My upbringing is governed by, has colored my thinking on many things. Growing up in a financially humble home, I have more than just sympathy for those in need. I come at it from an empathetic standpoint. We'll talk perhaps about those with intellectual disabilities. There was a family next to me when I was a kid. I lived out in the country in a little town of 250 people. There really wasn't anything there. There was no stores, no gas station, no post office, no schools. You had to go to town for all those things. But the closest little house to us on this little village road we lived on was a family that had 2 children, the youngest of whom was a girl named Lori who had intellectual disabilities and used to ride the school bus with us. It was a very different day and age. The ways in which people addressed the needs in the community were very different. This was, 40-some years ago. And so to that end, I see how we have made progress, but how in this state we have so much farther to go. And the cost of everything comes at the cost of something else. There is an opportunity cost to things. It's imperative that we make wise choices, that we are good stewards of the taxpayers' money, to ensure that there is the ability to provide for those who truly have the greatest need. I've never been an elected official. If you're looking for somebody who's a professional politician, you have that choice in this race. And while he may or may not ever stand before you and have this conversation, he pays people. This young woman in the back follows me around everywhere I go, tapes every word that I say. That's how he expects to win. To try to play gotcha, to hope that I'll say something that can be snipped out of context and put into a negative ad. You see these ads being run right now, where literally 1 and 2 words will be taken out of an entire half an hour of discussion and made to seem as if I'm saying something else. If you want more of that, you have that choice in this race. I frankly think it's destroying not only our political process, but destroying our state and destroying our country. I think we deserve better than that. I am a business guy. I do employ a lot of people. I own all or part of 10 different companies. And they do range in, as was noted, from base level manufacturing to medical devices. I have a device company here in Louisville that we actually just got 510K approval from the FDA 2 months ago. It's an electroencephalography device. It measures the electrical activity in the brain. Interestingly, we were focusing on this being used in cognitive disorders, specifically Alzheimer's. But right now it's being used in clinical trials related to Down syndrome, TBI, and others as well. But these are the kind of things that intrigue me. I'm intrigued by a variety of things, taking ideas from the minds of those of you that are students, those that have moved on from academic ranks, and taking those ideas and turning them into opportunity. I'm an entrepreneur. I've spent much of my life in the investment management business. I will tell you that no matter what profession you're seeking to go into, and most of you obviously are choosing similar professions, doesn't matter what profession you go into in this state, if we don't get our financial house in order, the gig is going to be up. Increasingly, we have made it too difficult to do business in this state. Any of you that would become an OB in this state, my gracious, it'll be a 6-figure policy at a minimum just for insurance, just to be able to practice, which is why increasingly numbers of our children in Louisville are actually being born over the river in Indiana. There's a whole ripple effect of things based on the decisions you make at the ballot box. I challenge you to be mindful of these things. We'll talk about some of these things as we go forward. I have a brother who's a specialist. My wife used to be a charge nurse in an ER. She also worked labor and delivery for many years in a rural hospital on the night shift, which if you're the labor and delivery nurse on the night shift in a rural hospital, it means you deliver most of the babies, actually, because the doctor's on call and usually gets there after the baby has arrived. So I've seen this from a lot of different perspectives, not only within my family, but just even from involvement I've had on the business front. But I mentioned the investment management side of it because, frankly, that's critical. We've got to fix the pension crisis in this state. It affects everything that will touch your lives. I've spent most of my life in the investment management business. I started a firm here in Louisville, actually, in the basement of my home initially, that today manages more than $5 billion in pension assets. This is an area that I understand. It's part of what drew me to this race. I'll simply say this in closing. We need to make a change, of course. We do. We're struggling as a state economically. We have folks that will tell you that all is well, but it's not well, and you know that. The hospital community is struggling, the healthcare community in general. Doctors are increasingly being suppressed. You're being expected to do more and more with less and less interaction with patients, less and less reimbursement, 80 cents on the dollar. You get 2, 3, 6 minutes maybe with a patient. We're removing you from the ability to do what you're trained to do, what you have a passion to do, what many of you have felt called to do and are in the process of becoming. We've got to change this. It's not working well for us in this state or in this country. And if we're going to have 70% in some communities that are on Medicare, Medicaid, and reimbursement rates for CPT codes to the degree that they're being fought back and you're getting rejected 2, 3, 5 times over 8, 9, 10 months, and ultimately you get reimbursed 80 cents on the dollar. If you're getting 80 cents on the dollar for 70% of your patients, that's 56 cents of the dollar that you need just to keep the lights on. That means you have to find 44 cents out of your other 30% of your patients. So you need 44 cents from the 30% just to get back to breaking even. It's not sustainable. And when we expand programs beyond their intended use, it comes at the expense of the very things that, frankly, these programs were intended to do, to provide for people in true need. So we'll talk about some of these things. And I look forward to it. I appreciate your attention to this issue. I appreciate your interest in this race. I would humbly ask for your consideration for your vote. I'm not here as much to politic as I am to have dialogue with you, to answer questions that you have. But please be engaged. I'm a former military officer, as was noted. I served with guys that are dead. Guys whose kids grew up without a dad. We have 12 hours to vote. 12 hours on November the 3rd. Take it seriously, no matter who you vote for. Whether you vote for me or whether you vote against me. Please vote. It is the greatest privilege we have. An extraordinary sacrifice has been made to allow this to happen. Please do not abdicate your responsibility because it will affect you in more ways than you have any realization. And again, I appreciate you inviting me to speak to you today, and I look forward to our conversation.
Now we're going to move into the question and answer portion of this event. Joining Dr. Josh and Matt Bevin will be Akash Chougule. He is the Deputy Director of Policy for Americans for Prosperity. So if we have any audience questions, just feel free to come up, grab the mic, and let them know what you want to know. Okay.
Just project and then we'll repeat if it's not clear enough.
I guess this question primarily for Dr. Josh, but other appropriate. Where would a proponent of socialized medicine and the Affordable Health Care Act be most critical of your direct care model?
Where would a socialist disagree with our direct care model? Probably everywhere. In the sense that it's not paid for by the government. It's individualized. It gives the physician a lot of autonomy, the patients a lot of autonomy, and it's not centrally regulated. And so just like they try to control Uber, something that the general population seems to love and embrace, then governments want to come back and take their piece of it or restrict or control that. And so the fact that we are free of insurance regulation, of government regulation to a large degree, obviously we still have to maintain licensure and provide appropriate care, etc. But I don't have to do what CMS says because CMS, Medicare, Medicaid, doesn't pay me. So I have a lot more flexibility. They probably wouldn't like that. Often we hear, well, what about the hundreds of millions of Americans that can't afford $10 a month? Well, and obviously that's a gross exaggeration of the population and the revenue. I think they reject the idea that the free market can help with anything. I was in a webinar yesterday with a bunch of Harvard physicians who said, well, medicine is sacred and is above business. And I would say the exact opposite. I would say that medicine is so important that we must treat it like a business and respect the value that gives to the patient. Because when it's a business, they have control, they have power, they're a customer, and we have to respond to their needs in a way that brings value, that brings affordability, that brings convenience. So I think if we have a socialized system, we'll have all the care and bedside manner of the DMV with, and if we had a free market approach, it's Netflix, it's Uber, it's any other growing, valuable service, and we should be proud of it.
And ironically, let me add one thing. In addition to what was just said, ironically, you'll have that, but at a cost that's frankly prohibitive. If you look at what we spend in this state right now for folks on Medicaid, nobody actually knows the exact number. Every estimate, every study that has been done by our legislators, by those in the cabinet responsible for overseeing this, for those even at the CMS level itself, every study that has been done shows that on average we spend somewhere between $6,000 and $9,000 per patient on Medicaid in Kentucky. Let's just say it's in the middle. Let's say it's $7,500. What could you get for $7,500 in addition to concierge medicine? At $2,500, $3,000, you could get top-notch access to concierge medicine. You'd still have several $1,000s left over that could be used for catastrophic health insurance policies and probably still have money left over. Government as the conduit for taxpayer dollars, regardless of the intended end use, is not the most efficient. I would challenge any one of you to think of any arena whatsoever, healthcare or any other, where there is a private sector alternative, where the government also offers a solution, that the government does it better, does it more effectively, does it more efficiently, does it in any way, shape, or form in a better way than the private sector alternative. The reality is there is no such example. I asked this of a woman who told me immediately, well, healthcare. And I thought, well, that's an interestingly bad example to use. And I asked her why, and she said, well, because now everybody has access to health care. But in reality, that's not the case. And while indeed we put more people on Medicaid, if fewer and fewer doctors are able or willing to take Medicaid patients, what have we truly given people? The reality is you can no longer afford to see them in light of the suppression of reimbursements on other fronts. And so to that end, it's almost become counterproductive with respect to expanding these things. And I reminded this woman that in reality, the only true example of what she was claiming, where there was truly a healthcare monopoly offered by the government in this country, is the VA system. In the VA system, where you truly have government-run healthcare in its entirety, is completely broken in large measure. And she reminded me, well, that's now not the case. They used to have problems. She said, but now they get vouchers. They can go to any doctor they want. And I had to remind her that those doctors they're going to outside of those systems are folks like you. These are people who are private sector doctors. They're not forced to be a part of the system. You can't make you all go through medical school. We can't force somebody to become a doctor. If you were robots, it would be one thing. It is not an option that we do that. And in reality, if the VA did not have this backup system called the private sector in the free market economy, where then would people go? If the entire system was like the VA system, what would be the backstop? And this is why it's imperative that we realize there is a role and a purpose for government. And there is a role and a purpose for the private sector. And they should be kept in their respective channels of expertise and responsibility. The Constitution of the United States is very clear. There's a handful of powers specifically enumerated, spelled out for the role of government. Our founding fathers were wise, and they understood the importance of ensuring that you have the laws of economic advantage, where those responsible for certain areas are focused on those certain areas. Healthcare is not a constitutional right. It's important for us not to confuse that.
Yeah, I mean, I would just add to your original question. I think one of the things that Mr. Bevin does really well is not to impugn the other side's motives. I think it happens way too often in politics. I mean, I live in Washington, D.C., and it's annoying and disgusting and counterproductive. But I think that there's, for a proponent of socialized medicine, where they might be critical of a direct primary care model and things like that, is almost like a lack of trust or lack of faith in the free market to provide the things that they want to be able to provide to people, which is access to quality, affordable health care, which is what we all want. But that being said, I think that what this model does better is address what the original problem was that the Affordable Care Act sought to address. I think that they kind of missed the point. I think that the Affordable Care Act and proponents of socialized medicine, they too often conflate health insurance with access to health care, which Mr. Bevin touched on just now, which is that we can put a taxpayer-funded health insurance plastic card in everybody's pocket, but what does it mean if nobody will take it? What this solution does instead is it gets to the real problem, which is not the number of people who are uninsured, but the cost of health care. And the cost of health care is expensive because we have mandates, regulations, and all kinds of things that add costs. Not only that, but it has not been transparent ever. I mean, I can't think of a field that's less transparent with costs than health care, and maybe I'm missing something, but I grew up in a family of doctors, and I don't know how many people in here, and you tried it too, but how much does procedure XYZ cost? I mean, almost nobody knows the answer to that for anything. This solves that, and obviously transparency, competition, and consumer choice is what controls costs ultimately, which is going to expand that access for more people to quality, affordable care, rather than just the insurance solution, which is just one small part of solving health care, I think, more broadly.
I like the point about seeing the other side's motives. Steve Covey has a great book, The Third Alternative, and we try to position the direct care alternative or option as that third alternative of it's not left, it's not right, it's different. And so if I may use standard terms, the left would say we want more care for more people, however that is, typically government run. The right would say, well, we need to be financially wise with the limited dollars that we have. And there is an option, even though those feel like contradictory, to say, well, how do we get more patient care for less dollars? That's the task of every private sector business, essentially, more value for less cost. And direct care, whether it's the Surgery Center of Oklahoma, that's a insurance-free surgery center that's often 8% less, or the Phi Group that will pay patients to go to cheaper alternatives, so a patient could leave Boston, go to Oklahoma, have their hip surgery done, and be paid $20,000 by their insurance company because they're aligning incentives for savings. Or direct care that says, we're getting your unlimited visits, no copays, free procedures, wholesale meds, labs, imaging, pathology. We're getting you all that for 95% less than what the government is already paying for. So now, in a unique way, we meet the left and the right's goal. More care for more people. We're not going to eliminate Medicaid overnight. So then you have more dollars to put for more care for those people designated as Medicaid eligible. But at the same time, you're being fiscally sound for budgets, which are a very real problem, because like Matt said, that affects everything the state does. So I would challenge you to look for those alternatives that, although hard to find, do meet both criteria.
Dr. Umbehr, right?
Yes, Josh.
Yeah, thanks for everything. One of the criticisms of direct care plans is that it is sort of lax with evidence-based medicine models, that like a patient can come in and be like, I really want an MRI, that's prospect on TV, y'all just do it because it's cheap for you guys. How does your practice and how does that neural model cooperate with evidence-based medicine to get patients?
I wouldn't say that that's a criticism, and I don't think we hear that too much. It's amazing what you can do with good evidence confronted or provided to the patient so they can make good decisions for their own care. So we would use evidence-based medicine to say, as a population, your back symptoms wouldn't suggest that you need an X-ray or MRI for 6 to 8 weeks. So, Mrs. Smith comes in, she has back pain for 2 or 3 days. We talk either by phone, text, email, office visit, home visit, etc. You have no red flag symptoms. Here is what the evidence would suggest you do with your dollars. And actually, when you put the patient, it is behavioral economics at its finest. It's what insurance and government has always understood, is that you have to have the consumer have a little bit of skin in the game, in that first dollar skin. So when a patient has saved $3,000, $4,000, $5,000 on their insurance, hopefully put that back towards an HSA, or are now just spending their own dollars, they're going to ask me, not, hey, can I have an MRI because someone on TV said it was a good idea, when I say, okay, sure, it's $400. Now, cash price normally, locally, would be $2,000. So we have lowered the price for you to 80% if you are just that curious, that your value and risk tolerance and desire for evidence is one, and it's going to be different for every single patient. So I'm not making the decision for them. The insurance isn't making the decision for them, but I've made the delivery of care that much more affordable. But I can promise you, when I tell a patient that your name brand Effexor is $400 a month, and I can get the generic for about $7 a month, I've never had anyone take the name brand. When they get to see, and because of the lack of price transparency, there's another great example, Areva, name brand, generic with flutamide, that we get for $10. The generic at the store with the coupon is $50. Without a coupon, it's a few hundred. Name brand is $1,200, no coupon. Well, I don't have anybody take the name brand, but I give them the evidence to show them how to make their best decision. I'll order either one. There's no skin off my back. I'm just ordering the medicine that they're going to ultimately pay for. So then they demand that we give them the best evidence so that they can make the most cost-effective decisions for their own dollars. When they only have to put $10 for themselves down for their copay and the insurance is on for the rest, behavioral economics would teach us that the psychology of that is you'll always spend someone else's money easier than you'll spend your own. And that actually makes sense. For $10 of my money, I get $500 of value that someone else pays for. That's a good deal. I'll take that. When it's raising my insurance and the delayed effects of that are bad, but I don't see them, I'll make that decision that's bad for the group and bad for the individual. When it's my dollars, if I make more claims, my insurance will go up. If I don't make more claims, my insurance can actually go down in our experience. Then they say, all right, I would kind of like an MRI, or I would like an antibiotic because that's what I think I want, but I, as their paid advisor, is going to tell them what is the best evidence. And no, it's not an antibiotic. This is concierge medicine or direct care medicine doesn't mean you have unlimited access to my script pad to ask for whatever you want. It's you get to ask me for the best advice. You want antibiotics when they're not appropriate, I'm not going to give them to you. If I ask my mechanic to put the wrong tire on, he's not going to do it because it clearly doesn't make any sense. If I ask my accountant to do something that's not legitimate, he's not going to do it because he'll go to jail. And I might too. So it's working. So even though patients may ask for something that's not in their best interest, it's our job as physicians to give them the best evidence to show them how to make the best decision that ultimately for themselves.
It's also the job of people in elected office to understand that same mentality, which is why it is critical to elect people with private sector experience, real-world experience. Because in reality, it has been increasingly proven that if you have skin in the game, if you have a vested interest in the outcome, you're more likely to make wise decisions that ultimately affect you well. Studies have shown that people on Medicaid have worse health outcomes than people with no insurance at all. So simply having access to something may or may not lead to the result that you want. And it's important that as a state, when you're strapped, and we have 25+% of our state now on Medicaid. It's unsustainable in just sheer dollars, and yet the need is there or people would not be on it. It's trending toward 30%. So there is what I've proposed, and frankly is going to need to be done by whoever the next governor of the state is we're going to have to apply to CMS, which is the disperser of the Medicare, Medicaid dollars, for what are known as 1115 waivers. And 1115 waivers allow a state to essentially get the equivalent of a block grant to customize a solution that can have gradations, that can have various degrees of amounts of expected skin in the game from people based on their income levels, etc., that ultimately empower people to start making the kind of decisions that are in their own best interest. And indeed, when you give someone a choice, if they have an allotment of X number of dollars that is theirs to make decisions on, that is really coming from the taxpayers but has been allotted to this individual, and they can spend 7 or they can spend 70, they'll choose the 7. This idea that people in need somehow don't have the capacity to make decisions for themselves is an insult to these people. And it's wrong, and it's an insult to the taxpayers that are funding it. I never had health insurance in my entire life until I was a military officer. First time I ever had any health insurance. I was an active duty Army officer. So I know from personal experience. I have scars on me as thick as my finger that might have been stitched up, well, should have been stitched up, but weren't. I tore the meniscus in my knee and never was able to get it fixed. It bothers me now. Someday I'll probably have to get it looked at again. But the reality is I didn't have any recourse at the time to do anything about it. We want to ensure that as many people as is absolutely possible have access to the system. One thing you all are going to hear about, in this state or any state in which you practice, there will always be a battle talking about things like certificate of need, things like scope of practice. These are issues that you will hear about even as you're in school, you'll hear about as you get out there. And for those of you that are out there, there are tugs of war that are happening already. But we need to think about what is the best way that as a government, state, local, federal, whatever the case might be, we can be the best steward of those limited dollars, because they are limited. And where do we get the best bang for each buck to cover as many people as we possibly can? Yes, ma'am.
For the about 400 to 500,000 people that would lose health care without the Medicaid expansion, do you expect direct primary care to replace Medicaid for all of these people as their primary health insurance?
But now, to explain to me what you're saying, the 400,000 to 500,000 people, who's losing their health coverage and how?
Without the Medicaid expansion.
Without Medicaid expansion. Okay, so I think I understand where you're coming from. Let me try to qualify. And the question is, what then happens and who picks up the cost of that? We had about 850,000 people on Medicaid in this state prior to Medicaid expansion. That was when the threshold was about 106% of the national poverty level. We've then upped that to 138%. In so doing, we have, to your point, added about another 440,000 people to the Medicaid rolls. I have made clear that I will not continue to enroll people at 138% under the existing model. I've made that very clear. Now, there are already 1.25 million people on it. This doesn't affect them at this point. We're not going to re-enroll people at that point. We're not going to add new people to it. But we are, with these 1115 waivers, going to come up with a solution to ensure that ultimately I'd love to be able to cover people on a graduated level to potentially even higher degrees as well. But they're going to have, as has been noted, some skin in the game. They're going to have to take some sense of ownership. People frankly want this. People need this in some measure. And ultimately, the intent is not simply to have people on Medicaid. That's not the best health outcome or source to health care for anybody. It is an avenue. But let's be honest about this. This was supposed to have been precluding the emergency room from being the primary care stop for people as their first stop onto the health care avenue. That has not been the case. In fact, as we have increased the number of people on Medicaid in this state, we have not only in absolute numbers, but as a percentage of all the people seeking health care in this state, seen the trips to the ER as the first stop in primary care go up on both fronts. So it has had the exact opposite effect. So we have only exacerbated the problem that we thought we were going to alleviate. So in reality, if we were to have fewer folks, it isn't going to put any more or less burden on these emergency rooms and healthcare providers than was already there. In fact, maybe less, because now people are under the assumption, well, I have a cold, I'll just go to it's 3 o'clock in the morning, and I'll just go to the emergency room. Some of that's education, understood. But the reality is that the healthcare system ultimately bears the burden for this, one way or the other. The costs ultimately are compensated by somebody, and that somebody is the healthcare system, the doctors, and ultimately the taxpayers who are in large measure subsidizing this. So this isn't an effort to turn anybody out on their ear, but rather figure out how do we cover these folks in a way that's actually cost effective.
The other thing I would just add is that there is precedent to this. So I don't think anybody is advocating just a cold turkey repeal of the Medicaid expansion. It's been done in two different ways, to my knowledge, which are, in Tennessee, they had the same situation. This is before the Affordable Care Act. They expanded Medicaid, and exactly what Mr. Bevin is talking about happened. It was eating up a third of their entire state budget. It was taking up money that was meant for roads, schools, public safety, blah, blah, blah. And it was just clearly unsustainable. They had no choice. A Democrat governor repealed the Medicaid expansion there cold turkey in 2005. I think within a year, something like 60% of those people found jobs, and the vast majority of those who found jobs were able to get private health insurance. And I think one of the impacts we've seen of the Medicaid expansion here and elsewhere is that it's not all people who were previously uninsured. A lot of these people, the vast majority, I think 80% are able-bodied, childless, working-age adults who are, these are people who, in the right kind of economy would be working and would, hopefully have access to employer-sponsored health insurance. People find access that way. The other way states have done it is that they do what's called an enrollment freeze. And so Maine did this, Arizona has done this in the past, where same thing, they expanded Medicaid eligibility, found it to be completely unsustainable, eating up resources that were meant for very vulnerable populations. Looked for a solution. They capped enrollment. They said no more people in that newly eligible expansion population can enroll. And over time, within 30 months in Arizona, for example, the enrollment of the Medicaid expansion by itself fell 70%. And that's as people, as the economy improves, people get jobs, their incomes improve, they can afford health insurance on their own. So I don't think that it would ever be a situation, 1115 waiver or not, repealed, enrollment freeze, whatever whatever avenue they might pursue here in Kentucky. It'll never be a situation of you repeal a program, all of a sudden 400,000 people are out on their own cold turkey with no solution.
It's literally not even possible. It doesn't work that way.
It doesn't work.
People who will tell you that it's a scare tactic, that somehow people are dumped to the curb. It literally does not work that way. You don't just unenroll people. It doesn't work that way. It's not legally possible.
So exactly. So I think that a lot of that is, I don't know if I would call it fear-mongering or what, but it's a problem that would not be the case, and it's ignoring the larger problem that we have, which is that Medicaid is ultimately a money loser for the state. It's a money loser for hospitals. It's a money loser for doctors. And it's not sustainable to be adding more and more people onto this program that in the process is hurting the most vulnerable patients. So I think that, and that's when you have to start looking again away from the insurance conversation towards the supply side conversation that increases the number of doctors, the number of providers, and the access that people have, which gets to things like certificate of need laws, the scope of practice, medical malpractice reform, which are things that, I don't know if they're covered or not in med school, but they're certainly something that need to become a part of the conversation here and elsewhere.
This state needs tort reform to be passed. We are not user friendly for the healthcare community given our current legal construct. We just are not. And that makes this a very expensive place to practice medicine. And this is not serving our underserved population well. It's not. We're compounding an existing problem. We don't suffer from too many doctors, frankly, in this state. Quite the opposite, unfortunately.
Well, I've testified before our state house on the same topic, and the phrase we like to use is we can pay for patient care or paperwork. It's hard to pay for both. It's less about how many people we cover and how cost effective can we cover them. So if the state can get blood work 95% cheaper, they should, because that is being good stewards of the state's coffers. And then if you cover more people, great. If you cover less people because they don't need Medicaid, great. But I think all roads lead back to jobs. All jobs are based on the cost of health insurance. If you can decrease the cost of health insurance because of the direct care model by 30 to 60% year one and progressively even further, that means more people have more jobs getting better insurance, naturally, through attrition, getting off of the Medicaid rolls. But we priced it for our state. We spend $3 billion of our $17 billion budget, or trillion, on healthcare. We could provide private insurance, pay the premiums, pay the deductibles, pay actually $60. So we doubled the math, higher than my average revenue per Medicaid patient, and would only cost 1.3. So roughly we could save the state $2 trillion if we moved 100% of Medicaid people to private insurance, paid for that, paid for their direct care doctor, but because it would take advantage of cost-saving measures the free market can find. Not cutting care, not limiting that, in fact, broadening that, giving each one of these Medicaid patients a valuable doctor available 24/7 by text, email, phone call, etc. We're removing the red tape that is dragging the system down. So it is very much not about covering less people. How do we spend those dollars more effectively so more people can get affordable care?
And at the end of the day, that is the point. That is literally the point of this. And this is what I think has called a lot of you into the medical arena, is that you want to be a part of providing these kind of solutions to people. We want people to have as much access as is possible. This is not a political issue. It transcends partisanship, and it's imperative. And frankly, we're blessed to live in a country where we have this as a possibility. I've been in more than 20% of the countries in the world, and I'll tell you, in most of them, these things we're discussing are inconceivable even to imagine that we could come up with a solution for.
The other final point I would just add really quickly onto that is that it's not a red or blue issue. I mean, Medicaid expansion, Obamacare obviously have become very red or blue, but a lot of these other solutions, I mean, one of the things that we point out, like Texas is, obviously known for a very, very conservative state. They have surprisingly restrictive healthcare regulations. So it's not ever a red or blue issue when you get outside of the insurance conversation. Like when you look at things like the medical malpractice system, they reformed their system 10 years ago. Certificate of need laws are something that Florida, obviously a purple state, is going after. North Carolina and South Carolina are both red states. They're going after it. I believe Washington State has explored some of this stuff. So these are things that just are not part of the conversation enough that we need to start getting towards once we get past the insurance conversation, the Medicaid conversation, that can really start improving access to quality, affordable health care for people rather than just being obsessed with putting an insurance card in their pockets.
Okay. So it's 1 o'clock. It looks like a lot of people already left for class. So we're going to go ahead and finish up here. I don't know about you all, if you all have somewhere to be after this. But if you have any other questions, I encourage you to come down and see if you can get them answered. So thank you all for coming out today. I really appreciate it. And give it up one more time for our guests.
I want to share one thing with you. Give me 15 seconds. I want to share one thing with you as encouragement to you who have chosen the medical profession. I heard recently of a doctor who had a plumbing problem at his house, and he invited a plumber over to fix it, which he did. And the plumber fixed the problem. It took him about 45 minutes. He gave the bill to the doctor, and the doctor said, "Good grief. I mean, I don't mean to complain." He said, "I called you. You fixed the problem. I'm a doctor. I'm going to pay you. But wow, really? I mean, you weren't even here an hour." And he went on and on and on. Finally, the plumber put his hand on the doctor's shoulder and said, "Listen, I understand exactly how you feel." He said, "I felt the exact same way when I was a doctor." So for those of you who, despite that sad almost reality, have chosen, thank you, as the father of 9 children, and 4 of my children are adopted, and some of them had some real health issues early on in their lives as part of our family. I appreciate what you're doing. I appreciate the long road ahead of you, the long slug that you have, the long sleepless nights that are yet to come for you, and I appreciate you doing it anyway. So thank you. Take care.